Hi there, this is Dr. William Mohamed Chansa, and in this video I'll be taking you through history taking in internal medicine. So before I start, I would love to mention that this history taking that is I'm going to record for internal medicine can also be used in surgery. So if you're in surgery, you can still use this same video to learn on how to take a history in surgery. Okay, today's objectives are very simple and straightforward. Number one is to know the introduction to history taking, components of history taking, detailed of the components of the history taking, then we'll do the summary afterwards. So what's the introduction to history taking? So this is arguably the most important chapter that you will read in medical school. Even in the 21st century, with all the rapid and exciting advances in biology, computing, excellent history taking remains absolutely central to best practice in medicine. In short, you can't do medicine minus history taking. History taking should take precedent. It should be the first thing that every doctor needs to know. Okay, we have got, of course, laboratory scientists, okay, or biomedical scientists, and also radiographers. But despite having them, before you even reach to investigations, you have to take a history, then we can examine our patient, and then we can investigate based on the findings from the history and also from the physical examination, and that's how you become a medical doctor. Okay, the patient must be your primary concern. As a doctor or a medical student, you have a fundamental duty to understand your patient's stories, including the background context, to help and to heal. You need to learn what your patients have experienced and what they feel. In short, you cannot treat what you don't know. So you have to know how the condition started, how it began, what risks the patients to have the same condition, what could have caused the condition, and that's what the history is going to give you in total. Yeah. And then also it will tell you about the patient themselves, how they have coped with the environment and everything. That's what the history is going to tell you. Okay. All that you need is right in front of you. Ask questions. Okay. Take a good history. Every little detail is perpetual to becoming a good doctor. Take history and again and again and again, history again and again. That's what Dr. Tehari said. So Dr. Tehari is a consultant physician at Levy Manasa University Teaching Hospital under Unit 3. So his emphasis is on about taking a history. Always take a history. A good history is what makes a good doctor. So make sure that you know how to take a history in layman's terms. So now there are fundamentals that we have to remember that are important for history taking. Remember that the information that the patient is going to tell you is confidential. Okay? Make sure your patient feels comfortable as you take your history. Make sure that you maintain privacy so that the neighbors that have come to see them, they do not get the information. Okay? The information about their condition, about the patient's condition. So you maintain appropriate eye contact. Make sure that you are comfortable and the patient is also comfortable. And check that the patient is feeling physically comfortable as you talk to them. Because we might be maintaining the eye contact, which makes the patient uncomfortable. So make sure that the patient is comfortable. So make a conscious effort to listen to the patient and establish a rapport, which is a relationship that you create with the patient. So you should be smartly dressed, okay, to gain the patient's confidence, of course, and doctors are trained to be smartly dressed always. So write rough notes while questioning the patient, but remember, you make a detailed record at the end of the discussion or at the end of the conversation that you're going to have with the patient. Then after, you're going to examine them. So now, the record should be sequential, accurate account of the development and course of the patient's illness or illnesses, even if this is not the order in which the questions were asked. In layman's terms, you need to ask questions, but remember, sometimes we don't ask questions sequentially. But in layman's terms, after you've gotten the history, always make sure that you put things in order. They have to be in order from the demographics to the presenting complaint, history of the presenting complaint, and etc. etc. So it has to be that sequential, not disordered. A systematic approach to history taking and recording is the most reliable way to avoid misusing crucial information or missing crucial information. In short, you have to put things in order to avoid missing crucial information that is important. And then always be empathetic to the patient, use non-verbal skills, avoid medical jargons at all costs. Because medical jargons are only advised or can be used in a review of systems. That's what other physicians and doctors say. Others say don't use medical jargons. So that is doctors dependent. Again, the other area or component where you can use medical jargons is your summary. So in the summary, you can use medical jargons. Right. So now the question that comes there is, what are the components of the history. So there are about 11 things that you need to know about the components of the history. The first one is appropriate introduction. So in here, you're going to confirm the patient's details, demographics, which are the particulars, explain the reasons for consultation. For example, you're going to say, hi, Mr. Shansa. Kaka, the thing is that I've been asked to ask you a few questions. Okay, the doctor has asked me that I should ask you a few questions. Right. Is that okay with you? Can I go ahead with the questions? And then they say, okay, yeah, you can ask me questions. Then you start asking about their names, the age, and everything. We'll talk about these in details. Thereafter, we have got what is called the chief complaint, which is the main problem that could have brought the patient to the hospital. Okay, this can be 3, it can be 4, but usually it's dependent on the patient as well. And then from the chief complaint, I'll pass you through. Now you ask a question. Now you place a question for the chief complaint. From there, you'll move to the history of presenting complaint. So, history of the present illness, also called history of the presenting complaint. This is just an establishment of what could have happened to the condition, what happened as the condition become worse. Okay, what could have been the causes, what could have been the risk factors in this patient. So as a doctor, you need to have read a lot of conditions for you to take a good history again. So that's why we learn basic sciences before clinical sciences. Okay. After that, we are going to go to what is called review of systems. So on the review of systems, we want to ask about other things that we didn't have, that we forgot to ask in the history of presenting complaint. Or rather, not what we forgot to ask, but rather what the patient might be having, but they're not aware of it. Or they have it, but they didn't tell us. So you just want to probe if at all there's another system that is affected in this patient. That is under review of system. From there, we'll go to the past medical history, where we have to ask about whether the patient has got what is called medical conditions like diabetes, epilepsy, asthma, TB, hypertension, sickle cell anemia, and etc. etc. And then we also have to identify whether the patient has had an operation before their HIV status, also called RVD status, in the past medical history. From there, we'll go to what is called the drug history. So drug history and allergy history is one thing. Okay, you want to find out whether the patient is on drugs, okay, or they're allergic to drugs or some food. Why is that important? That is important because there are drugs that you, for example, if you give to an asthmatic patient, the patient is going to be, the condition of the patient is going to be worsened. Okay, that is why you ask about drug history. From there, of course, what is called the family history. So in the family history there, you want to really focus about the conditions that run in the family, or indeed whether the patient, there's anybody in the family that is having a similar complaint as the patient. Okay. And then the social history, also called socioeconomic history, does not only encompass the personal history and the hobbies, but rather it also encompasses other things like the their social economic status. All right, and we'll talk about that in details. After we've talked about the social history, we'll talk about what is called the travel history. So travel history is important, especially for the conditions that are endemic. For example, you travel, you go to Northern Province, then you acquire malaria there, you get malaria, then you come to Lusaka. So that history is very, very relevant in this context. And then after we've done the travel history, we'll talk about the summary. But before we go to the summary, because you can summarize this at your own free time with your colleagues. Okay, but you remember after you've done the travel history, you need to thank your patient. Okay, be very grateful to the patient because not every patient gave you this information. Others denied to say they cannot give you the information. But this particular patient gave you the full history, and therefore you have to thank them. Okay, you have to thank them, and then you can go on and summarize your findings. Then you give your differentials, which are just your different diagnoses that you've come up with according to the history and the questions that you asked. Okay, so now the components in details. The first one is demographics. So demographics can be easily remembered using the mnemonic NAGMOD. So you ask about the name of the patient. For example, I've given an example in the brackets, faith, any chance, and what you are trying to identify there is that you just want to know the patient because remember you will deal with a lot of patients on the ward, and you don't want to just give wrong drugs to the right patient. Okay, or you don't want to give right drugs to the wrong patient. That's why you want to know the name of the patient, and then you need to know the age and gender because remember there are conditions that are common in some particular age groups and some gender. Of course, there are some rheumatological conditions that are usually commonly seen in women than in men, so that's important. Then marital status, occupation, these are also important. Risk factors, remember. Okay, and then is the patient stressed in their marital in their marriage? Okay, where do they work from? What is the significance of that? So number one, there are occupational problems like occupational lung diseases. There are also um, other things that are important for or with regards to occupation. For example, if you want to do some investigation on the patient, there are investigations that you can do that they can afford and ones that they can't afford. And this is important also for the social history. Okay. And then after that is done, we got what is called the R, of which there are three. You've got residence. Residence also is also about the conditions. If you talk about Lusaka, for example, many of the commons they are prone to have cholera because of what? Because of the poor sanitation in those areas. So residence is very important. Then the region is about briefs. Okay. So there are some regions which do not accept blood transfusion. So that's important to know. So you don't give wrong things to the right patient. Okay. Then the referral is also important. You want to know whether the patient is coming to the hospital on their self referral or they were clinically referred by the clinic, hospital. Okay, maybe they wanted to do further investigations from your main hospital. That's why they referred that patient. Or they are coming to you for the first time. Okay, but all in all, you have to probe further in this clinical context. And then ethnicity and tribe is one and the same thing. It's about some conditions being common in some tribe, others are not common in some tribes. Okay. And then date of admission is very important. You want to know when the patient was admitted, whether something was done to them or not. And the date of clerking. When did you clerk the patient? Then the last thing is informant. You want to identify the person or the individual that gave you the information. Was it the patient themselves or it was the bedsider? So you have to indicate that also in the demographics. After that is done, you go to what is called the presenting complaint, also called the chief complaint. In here, you want to ask what really brought the patient to the hospital. And how do you ask that question? You ask to say, what brought you to the hospital? You ask the patient that question. Don't say, how are you doing? Because they'll tell you, I'm not fine. That's why I'm in the hospital. So you have to ask to say, what brought you to the hospital? That way you are trying to open up, trying to make the patient open up to you so that you can listen carefully, okay, and also you don't interrupt the patient. That way you will get more information from them. For example, you can say, Mr. Geoffrey, thank you for telling me about this problem. I would like to ask a few more detailed questions. Is that all right? Then they'll tell you more information because that way you've approached them nicely. Now, there's a question mark here because sometimes you can have three complaints. For example, you can have diarrhea, vomiting, and a cough. So how do you record them? So you record them in chronological order, beginning with the one that began first. So in this case, if a cough has been there for 5 months, you record 5/12. Okay. If the second one is diarrhea and it's been there for 3 weeks, you record 3/52 because you know there are 52 weeks in a year. And then if vomiting has been there for 3 days, you record 3/7. If vomiting has been there for 13 days, you record 13/7. That's how you record these things. So days, it's over 7. Right, in that chronological order, meaning that even when you get to the history of presenting complaint, you start reviewing them, we start talking about them in that chronological order, but beginning with the one that began first. So in this case, if it's a cough, we discuss the onset, how did it start, and when did it start? What is the characteristics of that cough? Is it sputum, or is not non-sputum, or productive or non-productive? All right. What things do you think could have caused it? What are the risk factors from the patient? That's why a medical doctor needs to read the condition before they come to clinical area. So so that you know the risk factors and the causes that you can ask for a cough. For example, in this case, a cough can be caused by CVS and what? GIT. I mean, CVS and respiratory system. Respiratory system. So meaning you talk about respiratory system in this entire history of presenting complaint. All of it, you ask about everything that is under respiratory system: a cough, chest pain, sputum stained, sputum stained, or blood stained sputum. Okay, you also have things like weight loss, night sweats, okay, fevers, and whatnot. All those things that fall under the chest, you ask about them. Okay, that's when you go to the cardiovascular system so that you can finish up with what? With a cough. So is it productive, non-productive? You've asked that already. Okay, any stroke, swelling of the limbs or legs. Okay, difficulties with breathing at night when they lie flat. Do they wake up at the middle of the night to breathe better, which is called paroxysmal nocturnal dyspnea or paroxysmal nocturnal dyspnea? You need to ask about all that. After that is done, then you can go to the second chief complaint, which was what? Which was diarrhea. So you talk about the nature of diarrhea as well. And remember, diarrhea is GIT. So meaning you have to elicit everything about the GIT. So things like dry mouth, constipation, abdominal pains, blood in the stool, so called hematochezia, blood in the vomitus, which is also called hematemesis. Okay, and then melena, which is black stool. Okay, so you need to ask about all that. Finish up with the GIT, and then you can go to vomiting. Already the vomiting is under GIT, so that means you've already talked about it. You move to the next thing. Okay, but remember, these are some of the things that you have to talk about: progression of the illness, duration of the illness, things that would have make the symptom better, which is a aggravating factor, and things that would have worsened the condition, which are called exacerbating factors. And then you need to identify the associated factors, associated negative, explore the entire system affected. Make sure to explore the entire system that is affected, like I've mentioned above. Okay. And then the severity of the main complaint should be alluded to. So as that condition affected, the patient is there to day-to-day activities. All right. For example, if it's if they're coming to the hospital for the second time and the diagnosis is known, you can ask about when the diagnosis was made and what they used to diagnose the condition. For example, if it was TB, how was it diagnosed? Was it sputum, gene expert? Was it chest X-ray based? Okay, you need to ask about that. And then, are they on treatment? What drugs are they on? Okay, have they been compliant and adherent? So compliance is when the patient is taking drugs every day. Then adherence is when the patient takes drugs at the appropriate time and the dosage. That is called adherence. That's the major difference. Okay, but remember, if your main complaint was pain, whether it's a chest pain, it's a headache, it's a abdominal pain, you should use the same acronym to remember the components, which we call Socrates. So you need to identify the site where the pain is originating from, the onset, when did it start, and how does it start? What's the character of the pain? Is it throbbing? Is it pressuring? Is it sharp? Is it dull? So you ask about all those features, or throbbing. And then you ask about radiation. Does the pain radiate anywhere? For example, in pancreatitis, the pain radiates to where? The back. In myocardial infarction, pain radiates to the jaw and the left short and the left arm. So you need to know all those factors. What are the associated factors? For example, in myocardial infarction, the patient is going to have chest pain while they start also having excessive sweating, which you call diaphoresis. How long does the pain last? That is time course. How long does the pain last? What are the things that make the pain worse, which we call exacerbating factors, and what are the things that make the pain bad, which we call aggravating factors? And what's the severity of pain? So with regard to the severity of pain, you can easily assess the severity of pain in two ways. Number one, you can give the patient a score from 0 to 10. You say from 0 to 5 is mild, 6 to 7 is moderate, and then 8 to 10 is severe pain. How best can you grade your pain from the score that I've given you? That's the first one. The second one, you can ask about how that pain has been affecting their day-to-day activities. For example, they will say, me, I don't read. I don't go to school and I start feeling that pain. That means that pain is very severe. Okay, that's the second method that you can use to assess for severity. Okay, then now we got after we've elicited everything, you've explained everything in details in the history of presenting complaint. You can now go to the review of other systems. Remember, the systems that you touched in the previous section, you don't touch them in the review of systems. That's why you call it review of other systems. But in this case, since it's a tutorial, I just reviewed everything for you. So under central nervous system, you've got such kind of symptoms. Remember, I told you the significance of this component is that you don't want to assess whether the patient has got an association. Okay, they have got the problem in the other systems. That's why we're doing the review of other systems. And these are some of the things that you can ask about. So headache, convulsions, memory loss, blurred vision, limb numbness, respiratory system. You want to ask about chest pain, a cough, sputum. Okay, is it the cough? Is it productive or unproductive? Is it blood stained? Also called hemoptysis. Difficulties with breathing, which is called dyspnea, a wheeze, fever, night sweats, and the weight loss. I've already alluded to that. And then cardiovascular system, I've already talked about that, except for ankle swelling. I talked about it. PND, which is paroxysmal nocturnal dyspnea. I have mentioned that it's when the patient is waking up at the middle of the night to catch a breath. Make sure you ask about the number of periods that the patient uses. Okay, that's very important. And then the intermittent claudication is the pain that the patient feels when they walk over a specific distance. For example, if they're able to walk from point A to point B, which is 200 meters apart, okay, the moment they reach point B, they start feeling pain. That is called intermittent claudication. Remember, the distance is very predictable, meaning that it doesn't change unless the condition has worsened. So that distance from A to B is called claudication distance. That is seen in peripheral artery diseases. Eh? For example, in patients who have got atherosclerosis and many other conditions. Then GIT, we've talked about all these: diarrhea, melalena, which is black stool, dysphagia, difficulties with swallowing, and then odynophagia, pain on swallowing. And then GUT, just want to find out about how their kidneys are, ureters and the urethra are working. So how many times are they waking up in the night to go to the toilet or to use the bathroom? That is called nocturia. Frequency, how many times are they passing? Are they going to are they using the bathroom? Oliguria is reduced urine output, and this is for layman's terms, you can end there with the definition of oliguria. Yeah. And then dysuria is discomfort on urination, and then dyspareunia is painful intercourse. That is usually seen in PID and also maybe infections of the lower genitourinary tract in the female. Okay, and then you can have also what is called hesitancy incontinence, where the patient fails to control the H2P, that is incontinence, and then hesitance is when they're having that difficulties, or they are finding it difficult to start urination or to pee. Hematuria, blood in the stool, in the urine, sorry, and then discharge in the urine is also very important. Yeah, so breathlessness, see limb swelling, you can rule out the kidney issues, which can present with such kind of things. Now you have got what is called musculoskeletal system. This system is strongly associated with what is called the rheumatological system. So you just want to make sure that you rule out problems with the rheumatological system. Under the MSS, you ask about pain, swelling, weakness. Again, you need to know the differentials to why you're asking about anything. Arthritis, conjunctivitis, because this can be associated with what is called some of the rheumatological conditions like Ritter syndrome. So you read through that such kind of conditions as you go. And then endocrine system. Under this system, you want to identify whether the patient's appetite has changed. Are they eating a lot, but they are wasted? That is seen in hyperthyroidism. Are they do they have any history of weight gain whilst having a reduced appetite? You think of hypothyroidism. Are they passing a lot of urine or a large amount of urine, which is called polyuria? Or they're having excessive thirst, which is called polydipsia? These are seen in diabetes mellitus as well as diabetic insipidus. Skin pigmentation, eye changes, swelling of the neck, palpitations can be indicative of hyperthyroidism. Okay, bowel changes, if the patient is having constipation or diarrhea. Diarrhea is seen in hyper, while constipation is seen in hypothyroidism. Okay, and then you need to ask about their performance in the in the bedroom, so that you can rule out impotence. And then they will have any discharge, the breast discharge or milk discharge on their breast. That is called galactorrhea from their breast. And then from having reviewed the systems, we go to the past medical history. So the past medical history here, you want to identify the number of times that the patient has been admitted to the hospital for any obvious reasons, okay, or any previous similar illness, okay. And then after you've done that, you ask about what is called the deaths. So the diabetes mellitus, epilepsy, asthma, TB, hypertension, sickle cell, and then you ask about the HIV status of the patient. And now you ask the HIV status of the patient is to ask them to say, are you on any drugs? Or when last did you do the test for your HIV? Okay, and we just ask them to say, how is your blood? And they will tell you if they're on drugs, you need to tell them to say, what drugs are you on? Are you compliant? How do you take them? Then you want to know that whether the patient is consistently taking the drugs and they are adherent to the medications. So if they have got HIV, we say they are HIV positive. But when you're presenting, we record and report that the RVD status is what reactive verbal, because they just told us. But if you found that in the file, for example, you can say the HIV, the RVD status is reactive according to the test that was done. And then if it is non-reactive, meaning that they are HIV negative. Do they have any surgical history? You need to report it in the past medical history. Any accidents, head injury, especially accidents to the head, you need to comment about them here. So any cardiovascular disease like myocardial infarction, heart failure, okay, respiratory problems like maybe TB, which we've already alluded to, stroke, etc. So after that is done, you go to what is called drugs or drug history and allergies. So you need to list the drugs that the patient is currently on, and I gave an example to why we asked about the drugs that they're currently on. And then you need to know whether they are adherent or they are compliant to the medications. And then adherence is taking drugs at the appropriate time and the right dose. And then compliance is taking the drugs every day, but not at the appropriate time. That's the difference. Then food and the drug allergies. So the food and the drugs that they're allergic to, you need to mention them, because remember you give food in the hospital, and also there are drugs that you want to give that can actually cause or worsen the patient's condition. For example, asthma, you give beta blockers. Herbal medications, chronic liver disease and herbal medication, there is that association. So you have to really list that. So having said that, we move to what is called family history. So in the family history here, like I said, it's about identifying the diseases that run in the family. So you ask about any family history of that, asthma, TB, hypertension, DM, epilepsy, and sickle cell disease. Remember, the reason why you're asking about family history, in short, you ask about what is called the first degree relatives. your sister, your siblings, your parents, and then maybe your sons or your daughters or children, layman's terms. Okay, those are called the first degree relatives. Conditions that run in the family. Of course, TB doesn't run in the family, but if you stay in the house with the same family or with a member that has got TB, you're likely to have it as well, especially if your immune system is compromised. Do you have any history of a similar illness in the family? For example, if it's a cough, is but that is coughing in the family. That's all. From there, you can move to what is called social economic history. So here you're going to ask about it. Occupation, do they work? And I've already given a rationale to that. Do they smoke? If they smoke, then you need to calculate what is called the PACA. So PACA, you want to identify whether the patient is at risk of developing cancer or not. So PACA is equal to the number of cigarettes that a patient smokes per day. Okay, the number of cigarettes that a patient smokes per day divided by the number of cigarettes that are in a pack, of which we know to say in a pack there are 20 cigarettes. So if the patient smokes, for example, 30 per day, you say 30 over 20, then you multiply by the number of years that the patient has been smoking. So if they have been smoking for 20 years, for example, you say 30 over 20 times 30. So you get 900 divided by 20. Okay, 900 divided by 20, that is 0, 0, and then 2 into 9, that is 4.5. So you get a 4.5. But if you get a PACA that is more than 15, the patient is likely to be at risk of having cancer, especially lung cancer. But remember, smoking has been associated with different types of cancers. Okay, so you go to alcohol, you identify the type of alcohol that the patient takes, how frequent do they take that alcohol, okay, what type of alcohol is it, and for how long have they been drinking that alcohol. You need to identify that, and there are calculations that we do. But I'm not going to dwell so much in that because I'll make a video specifically for alcohol, about alcohol. Okay, housing, you want to identify the number of bedrooms or number of rooms that are in the house. Okay, you want to identify whether the house is well ventilated or not. How many people live in the same house? Okay, mention the water source, the toilet. You just want to identify the risk factors. Okay, cholera and whatnot, those conditions, they are very, very contagious. And also cough, pneumonia, TB, just to mention a few. And then travel history. Travel history, like I said, is very important. Any recent travel to or from where? We want to identify that because remember that some of the diseases are endemic, like malaria and hepatitis A virus. And then you thank the patient for their cooperation and time. Like I said, it's not everyone that is going to give you a chance to ask them questions. So it's very, very cardinal to thank them as you conclude or as you come to the conclusion of your history. Okay, from there you can summarize your findings. Now, this is just a typical example of how you make a summary of a history. So this should consist of at least 3 positives and 3 negatives. And then the history should be very precise. And it should give the people who are listening to the presentation the overall picture of what is in the whole history. Okay, if you give them 3 positives and 3 negatives, the doctor should come up with a diagnosis by the virtue of you just giving them the 3 positives and 3 negatives. That is how best the precision can be. So you have to be very precise in terms of what? In terms of giving the summary. For example, I'm presenting, instead of me writing their full names, I'll just say, I'll write their initials. I'm presenting FN, female 25, RVD, non-reactive verbally, a referral from Kaputa District Hospital for further management. She presented with what? With a headache for 6 days, which was associated with loss of consciousness, non-projectile vomiting, weakness, and then on and off fevers and tea-colored urine. However, so here if I wanted, I would have said black water fever. I would have said hematuria. Okay, but tea-colored urine is better. However, she denied any history of weight loss, similar illness in the family, yellow indiscretion of the eyes, and similar illness in the past. So you want to identify. So from the history, there are things that you need to know that are important. The positives that are pointing towards my diagnosis. Number 1, the referral. Okay, this patient is coming from Northern Province. Number 2, she presents with a headache and loss of consciousness, which is cerebral malaria. And then non-projectile vomiting as well, which is one of the components of severe malaria. Then on and off fevers, of course, malaria, meningitis, the headache also meningitis. Okay, but tea-colored urine is pointing more towards what? Malaria than anything else. So meaning my topmost difference is going to be what? Severe malaria, as you can see in the slides. Okay, and then what are my important negatives? So there is no projectile vomiting, there is no weight loss. So I've ruled out TB meningitis. Non-projectile vomiting, I've also ruled out what? I've ruled out meningitis in general. But remember, Never say never in medicine. So that's why I put meningitis as a differential. Okay, and then enteric fever because of the on and off fevers, and then also remember the areas that the patient is coming from. Okay, so enteric fever is one of the most important differential for malaria. Okay, once you just get stuck, mention enteric fever as a differential, then as long as you're able to defend it. Yeah, but because there was no yellowing discussion of the eyes, there was no constipation, there was no diarrhea. Okay, so that should point towards more towards what? More towards severe malaria. But you can have diarrhea in severe malaria as well. So meaning that's an important negative. So remember in the summary, you are permitted to use what? Medical jargons. So that marks the end of the tutorial. Thank you very much. Walumba, Zikomo, Twatasha, Little Mezi, Asante Sana, Mercy Boko. That was Dr. William M. Chansa, SMTCO. So now before I cut the call, before I end the call, I end the tutorial, I just want to give you my timeline for 2026, our SMT timeline. So it will be having online classes that will start on the 1st of February. Okay, February next month we'll start online classes. We'll be guiding from first year all the way up to the final year of medicine. Okay, and then we're also going to have physical classes in March. So in March we'll start physical classes, and these will be intense classes that will be very positive, impacting everyone out there. So I hope I'll be able to show guys right there. And this is just our structure, starting from the people that will be doing tuitions for you guys, that will be tutoring you in all the courses. If you have got any form of questions, any clarification, please don't forget to contact me on 0977 402934. Ladies and gentlemen, that was Dr. William M. Chansa, aka the Chairman Net. Please don't forget to like the video, don't forget to share and subscribe to my channel so that you encourage me to make much more videos for you guys. Thank you very much.